So next, the single factor assays using the PTT. Principle of single factor assays based on partial thromboplastin time. If PTT is prolonged and PT is normal, TCT is normal, no heparin therapy, but mixing study is the next step. If there is correction after the immediate and incubated mix, the operator suspects a congenital single-factor deficiency. So there is three factor deficiencies. First is the factor 8 deficiency, which is hemophilia A, or the most common single-factor deficiency disorder. Second is the factor 9 deficiency, which is hemophilia B, and the last one is the factor 11 deficiency, which is Rosenthal syndrome. So in this table, factor assays using the TCT, PT, and PTT test systems. For fibrinogen 1, the system, closed method, and modified thrombin clotting time. Then the prothrombin 2, the system is prothrombin time. And for factor 5 is PT. For factor 7, PT. For factor 8, PTT, which is partial thromboplastin time. For factor 9, PTT. Factor 10, PT. For factor 11, PTT. And for factor 13 is chromogenic assays. Their purpose is to regularly monitor prophylactic therapy, or to document the efficacy or on-demand therapy during bleeds or invasive procedures. For factor 8 assay reference curve, although the laboratory protocols vary, most laboratory practitioners prepare a series of 5 dilution from 1:5 to 1:500. Mixed with reagent factor 8 depleted or deficient plasma and tested using the PTT reagent system, generating a linear log graph. So in this table or graph, in this graph illustrate a calibration curve of factor 8 concentration plotted against the clot times obtained from the factor 8 assays using linear logs axis. So for factor 8 assay procedure, it's just the same with the other procedure, but it mixes each dilution with 100 ml of PTT reagents and mix with 100 ml each of patient PPP dilution and factor 8 depleted or deficient plasma mixture. Incubate at 37 degrees Celsius at 3 minutes. Add 100 UL of 0.025 m calcium chloride and time starts. The interval is seconds for each dilution is entered into the curve, and factor 8 in percentage or units per deciliter is reported for each. For factor activity results, it multiplied by 2, 4, and 8 respectively to compensate for the dilutions. So the result should match the results of the 1:10 dilution within 10%. But pag, if the result of the higher dilution do not match the 1:10 dilution within 10%, they are considered non-parallel. A factor 8 inhibitor or LAC may be present, and the assay cannot provide a reliable estimate of factor 8 activity. The expected the expected results and clinical utility of single-factor assays. Reference interval for factor 8 activity is 50 to 186 units per dl. Test is used most often to estimate the plasma level of factor 8 activity during the therapy. For hemophilia A and B, bleeds occur at activity levels of 10 units per dl or less. The factor assay offers poor accuracy at less than 10 units per dl. Clinically, elevated factor VIII implies a risk of venous thrombotic disease. For single-factor assay quality control, it tests a normal and deficient control specimen with each assays and record the results. Normal control results should fall within the reference interval. Deficient control results should be in the range of 10 units per dl, factor VIII activity, or below. If either control result falls outside the control limits, the reagents, control, and equipment are checked, the problem is corrected, and the control is retested. Records all action taken to correct out-of-limit tests. Control results are analyzed at regular intervals, or weekly is typical, to determine the longitudinal validity of the procedures. So, for limitations of clot-based single-factor assays, to reduce inherent variation, use commercial calibration plasma. So, the curve is included in each test run, and it must assay 3 or more dilutions of patient PPP to check for inhibitors. Selects a matching reagent instrument system with a demonstrated internal day-to-day coefficient of variation of less than 5%. If clotted, hemolyzed, ecteric, or lipemic specimens are rejected because they give unreliable results. Reagents must be constituted with the correct diluents and volumes following manufacturer's instructions. Stored and shipped in accordance with manufacturer instructions and never used after the expiration date. So, for Nijmegen Bethesda assays for anti-factor VIII inhibitor, it confirms and quantifies anti-factor VIII inhibitors, which are typically IgG4 class immunoglobulins. It only required when the inhibitor value is low. If a Nijmegen modification of the factor VIII inhibitor assay is used, inhibitory titers should be reported as Nijmegen Bethesda units or NBU per ml. So the percentage of factor VIII activity neutralized is proportional to the level of the inhibitor activity. For single factor assays using the prothrombin, PTT and the PT are both prolonged and the TCT is normal. It may suspect a congenital single factor deficiency of the common pathway. So there is 3 relatively rare factor deficiencies that give this reaction pattern and cause hemorrhage, which is prothrombin deficiency, factor V deficiency, and factor X deficiency. So for the last one, the factor 13 assay, it is the coagulation factor 13 is a transglutaminase that catalyzes covalent cross-linking bonds between the alpha and gamma chains of fibrin polymer. Cross-linking strengthens the fibrin clot and renders it resistant to proteases. It is the final event in coagulation, and it is essential for normal hemostasis and normal wound healing. But neither the PT nor the PTT is prolonged by factor 13 deficiency. So it ends my presentation. Thank you.